Good evening, everyone. We are now live. Madam Sabri, Dr. Sabri Savaika, ma'am. Please, ma'am. Ma'am, you need to unmute yourself, ma'am. Please unmute yourself, ma'am.
Yeah.
Yes, ma'am. Please go ahead, ma'am.
Good evening, everyone gathered here. I would like to welcome you all to this webinar on neuroanesthesia on behalf of Research Society of Anesthesiology and Clinical Pharmacology on this beautiful evening. I'm glad and overjoyed to see so many of you take the time out of their busy schedule and join us today. So I hope you all leave here learning something as we quest into the lectures, panel discussions, and other scientific programs today. A special thanks to eminent faculty and distinguished dignitaries, without whom this event would not have been possible. Before we dive into the scientific program, I would like to extend my heartiest thanks to respected President Madam of RSACP, Madam Dr. Indrani Hemant Kumar, our patron of the society, respected Professor Dr. Tej K. Kaul sir, President-elect Professor Dr. Naveen Malhotra sir, and Honorary Secretary Dr. Vishal Singla sir, who gave us this opportunity to conduct this academic feast. So I would now like to request our President Madam Dr. Indrani Hemant Kumar to say a few things today, this evening. Madam.
Madam, you are not audible, madam, please. Madam, you need to unmute yourself, madam.
Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, yeah. Everybody, it's always a pleasure to our usual monthly webinars, and a package of fantastic topics on neuro, and it's the hot topics as in suit. That is so much nowadays, because we have the one on the other one on traumatic surgery, and Kolkata has always been a dear friend. Sharbury is, right there to take us of neuroanesthesia and webinar. All success. Looking forward to hear all their wisdom, and wishing this webinar all.
Okay, thank you, ma'am, for your kind words. Now I would like to request our patron, Dr. Tej K. Kaul sir, to say a few things.
Ma'am, I think Dr. Tej K. Kaul sir is not here. Sir has not joined so far.
Okay. Sir, I would like to request our President-elect, Dr. Naveen Malhotra sir, to say a few words.
Good evening all, and welcome to the RSACP academic webinar series being held today on 19th May. President Dr. Indrani Hemant Kumar, dear Dr. Vishal, immediate past Vice President Dr. Sabri Savaika, distinguished teachers, Madam Vibhu Kalyani Das, Madam Amna Goswami, distinguished faculty, and dear friends. It's a pleasure that RSACP West Bengal State Branch is conducting this academic webinar today, and I'm very happy that I'm a part of this webinar, which are being held regularly every fortnightly since almost now 2 years or so. Thank you, Dr. Sabri Savaika, for being there and for conducting this webinar. Thank you to all faculty. Best wishes for an academic program. Let the academics flow.
Thank you, sir. Thank you, sir. Thank you very much for your kind words. And now I would like to request Dr. Vishal Singla to say a few words.
Good evening, everyone. Good evening, respected patrons, Dr. Indrani ma'am, Dr. Naveen Malhotra sir. Special welcome to Dr. Amna Goswami ma'am and Dr. Vibhu Kalyani Das ma'am. Thank you to each and every one of you for being here with us today. RSSP has always been pioneer in promoting academics, and we have been holding webinar every fortnight to keep abreast with the latest and everyday topics. Continuing in the same spirit, we would be holding this webinar is for the super specialty neuroanesthesia. And for today's topics, I would like to thank the West Bengal team and Madam Dr. Sarvis Vaika ma'am for bringing in the so relevant topics, especially the traumatic cervical spine injury, which is which every anesthetist is so close to the heart. I would also like to thank our chairpersons who would make the discussion interesting and lively and would keep everybody bound. And I would also like to thank the technical team of the webinar, Mr. Chaubeji, for the technical support he's providing, and for the live streaming of this show on the Anesthesia Television and on the YouTube. Once again, I would like to thank each and every one of you for being here with us, and looking forward to hear from you, madam. Please, ma'am. Thank you very much.
Thank you, Dr. Vishal. Thank you very much. Now it's final time to start with the scientific session, for which I will be handing it over to Dr. Kasturi Hussain Bandyopadhyay. Dr. Kasturi Hussain Bandyopadhyay, sir, I would like to share it. Can you? Is it seen?
Yes, yes.
Yes. Dr. Kasturi Hussain Bandyopadhyay, she is the consultant anesthesiologist in Medical Super Speciality Hospital. Having her major achievements, she's COLS, BCLS, and CCLS of Indian Resuscitation Council, and she has a very bright career. She received She achieved the Young Achievers National Award to institutes. And her area of interest are head and neck surgeries, acute pain management, onco anesthesia, pediatric anesthesia, resuscitation training, and postgraduate teaching. So over to Dr. Kasturi Hussain Bandyopadhyay to conduct the scientific session. Kasturi, please.
Good evening, everyone. Thank you so much, ma'am, for such a warm and generous introduction. I am honored, in fact, to get the opportunity to be here with such esteemed faculty, my teachers, my seniors, and my friends here once again on the RSACP platform. Without wasting any further time, I would like to go ahead with the scientific program. Right. Dr. Vishal, is my screen visible?
Yes.
Very much visible, ma'am. Please go ahead, ma'am.
Thank you. So moving on to the first topic of the evening, anesthesia in the endovascular suite. We all know that since the past couple of decades, endovascular neurosurgery has been a rapidly expanding field and advancing clinical area. And essentially, it actually is an amalgamation of traditional neurosurgery along with interventional neuroradiologies, and has undoubtedly played a very significant role in management of various complicated neurovascular diseases. Anesthetic management in such patients comes under the purview of NORA, or non-operating room anesthesia, which itself poses its own set of challenges for the anesthesiologist at the head end. However, this is further confounded by the uniqueness and the intricacies of the ever-evolving neurointerventional techniques. The speaker of this very intriguing topic is Dr. Ramamani Mariyappan, and we have Professor Dr. Amna Goswami and Dr. Professor Renu Bala as chairpersons for this session. It it is a matter of great pride and pleasure to introduce Professor Dr. Amna Goswami, a great teacher, a dedicated clinician, and an extremely passionate neuroanesthesiologist who have inspired many like me to develop a love for this subject. And she has been an ex-professor in HOD Department of Neuroanesthesia at Bangalore Institute of Neurology, Kolkata, and presently is a consultant neuroanesthesiologist, senior most neuroanesthesiologist at Park Neurosciences Center, Kolkata. She has been the past president of ISNAC, ISSP West Bengal branch, ISA West Bengal, and a whole lot of laurels are still there on our head, on our shoulders, and we are so proud to have her today. Thank you so much, ma'am, for accepting our invitation, and welcome on board. It is our privilege to welcome Professor Dr. Renu Bala from PGIMS Rohtak. Madam has been a faculty for 16 years now, and her areas of interest are neuroanesthesia, airway, obstetric anesthesia, and critical care. She has about more than 60 international and national publications. I thank you, ma'am, for joining us today. I would request Dr. Renu to introduce Dr. Ramamani. Dr. Renu, please. Madam.
Please unmute yourself, madam.
Madam.
Renu, madam, please unmute yourself.
Yes. Good evening. Thank you, Dr. Kasturi, for a wonderful introduction. And it is my matter of pride to share the screen with one of the pioneer of neuroanesthesia, Amna ma'am, whom we still look forward to. And the first speaker of today is Dr. Ramamani. She is Professor, Department of Neuroanesthesia, CMC Vellore. Her special interests are anesthesia for cerebrovascular skull-based surgery, pain management in spine surgeries, ketamine in neuroanesthesia. She has more than 50 publications and she has authored around 5 chapters in various books. She is a reviewer in IJ, prestigious journals of RSACP and JNACC. Now over to Dr. Ramamani, please.
Thank you, ma'am. Ma'am, can I share the screen?
Kasturi, you stop sharing.
Yes, stop, ma'am.
Can you see the screen?
Yes, absolutely, clearly.
Yes, ma'am. Thank you so much. Thank you, Renu ma'am, for the kind introduction. Actually, I would like to, thank Dr. Sabri ma'am for giving me this opportunity. Today, I'm going to speak on anesthetic management in interventional neuroradiology suite. Actually, this is a vast topic. There are many procedures being carried out, as ma'am said, Renu ma'am said, that so many procedures are being done interventional neuro. So because of the time constraint, and I've just put the important ones, and whenever time limit exceeds, I would like to stop there. And we all know that we can actually, the neuroradiology procedures are actually, we can actually classify them into diagnostic and therapeutic. And I'm going to talk about the therapeutic interventional radiology procedures only. So in that, we can actually classify them into occlusive, reopening procedures, and some of the miscellaneous procedures. So under the occlusive procedure, any patient who comes with a, giant aneurysm will be occluding. So it coiling or stenting of cerebral aneurysm comes under occlusive, and embolization of cerebral or spinal tumors, or embolization of AV malformation or dural AV fistula, or if we are planning for a carotid occlusion test also, it comes under occlusive procedure. And sclerotherapy for venous angiomas, embolization for epistaxis, and now the recent ones, MMA, middle meningeal artery embolization for chronic subdural hematoma, that is also comes under occlusive procedures. And among the reopening procedures, treatment for the acute thromboembolic stroke, and balloon angioplasty for carotid stenting, or if you are doing it for the vasospasm after the aneurysm rupture, that is also considered under reopening procedures. And then some of the newer procedures like venous angioplasty or venous stenting for idiopathic intracranial hypertension, and thrombectomy and venous sinus stenting for cortical venous thrombosis, all comes under reopening procedures. And some of the other procedures being done in interventional neuroradiology, like a vertebroplasty, kyphoplasty, and lot of interventional pain procedures, stereotactic radiosurgery, and WADA procedure. That is for actually memory localization, and SAFE procedure, that is super selective, anesthesia functional evaluation, and MR guided, laser intimal thermal therapy, and MR guided focused ultrasound for essential tremor. There are many procedures are being done, but because of the time limit, I will be discussing only certain whatever the important procedures being done in interventional neuroradiology. So what are the general goals during the interventional neuroradiology procedure? As a neuroanesthesiologist, we have to ensure that the hemodynamic stability is so much important, so that we can maintain the CPP and ICP, especially in a patient with a raised ICP. In a patient present with a subarachnoid hemorrhage, obviously they will have a raised ICP. So we have to avoid extreme swings of blood pressure. Either too high blood pressure will cause a re-rupture, or too low blood pressure can cause cerebral ischemia. And another next important thing is to maintain immobility. That will not only facilitate imaging, and also it avoids the movement induced vessel wall injury, because every time when the patient moves, guide wire actually can perforate the vessel wall, and it can rupture the aneurysm, or it can actually cause vessel damage. And also, as an anesthesiologist, we need to ensure that anticoagulation management is appropriate, so that we can avoid complications like thrombosis and embolism. And some of this procedure specific complication we need to know for each procedure, so that we will identify them immediately when it happens, and we have to institute appropriate measures to prevent complications. And also, not only these things, we have to think that these patients are critically ill patients and with a lot of comorbidities. So we have to keep that in mind. They are actually diabetic, hypertensive, and atherosclerotic, and they have a neurological injury. So all those things we have to keep it in mind and manage that also appropriately in the INR suite. And also, whatever we are doing, we'll try and get the rapid recovery of anesthesia, so that we can assess the neurological examination, and neuromonitoring can be done in the post-procedural period. And not only you take care of the patient, and also we have to take care of ourselves regarding the radiation safety, because the MRI, interventional neuroradiology suite, is the maximum amount of radiation exposure for the anesthetist. So we all know that Renu ma'am has already told that it is an anesthesia in remote location. It's an extreme challenge. So you have to actually prepare yourself for that. You need to assess the patient preoperatively very well, and you have to prepare the suite very well, and you need to know what are the complication is going to happen. If this complication happens, how do I manage? So not only the intra-procedural management is important, you have to have a post-procedural, how do we manage hemodynamics, oxygenation, ventilation, everything, so that the outcome is much better. So I'll be dealing this anesthetic management in the following category. As we all know that the preoperative evaluation is nothing different from common thing, which includes general systemic examination, airway examination. Apart from that, you need to assess their cardiovascular reserve. So why we need to do that? Because some of the procedure, neuroradiological procedure, as we will be discussing in next slide, and extreme manipulation of BP is needed. Sometimes you need to bring down the BP so much, so that the sensitivity of the test, especially in the carotid occlusion test, you have to reduce the BP to 20-30% from the baseline. And when you do that, if the patient has a poor cardiovascular reserve, he may not tolerate. So then he will end up in having myocardial infarction. So you need to assess how much cardiovascular reserve the patient has. Is it possible for me to, and if the patient is, if you are bringing up the blood pressure for some reason, is the patient is going to have a myocardial injury because of that? So all those things you need to assess during the preoperative evaluation, and you have to document the baseline GCS and neurological deficit, so that we can easily compare with the pre and post if anything occurs. And for all female patients in the reproductive age group, we have to do a pregnancy test, because in case if they are pregnant, and this high radiation exposure can cause fetal malformation. And so it is a must for female patients who are undergoing INR procedure in the reproductive age group. And we have to, most of the time when we do it as most of the procedures are actually emergency procedures. So we don't pay attention to the medication details. It actually end up in having a severe, a bad outcome, because these patients actually multiple comorbidity. They are on aspirin or clopidogrel or direct thrombin inhibitor or 10A inhibitor. So all the medication details we should know. And also, we need to know about the medications, what they are taking for systemic disease. And these INR procedures actually has, they inject a lot of contrast agents, so they can have a contrast-induced nephropathy. So you need to have a baseline renal function assessed, so that, we'll do appropriate measures to prevent further renal damage. And most of these procedures are emergency procedures, so we need to assess the fasting status. And it is very important sometimes if they are diabetic and if they are taking a protamine insulin, and we give protamine in case if there is a hemorrhagic complication, and so they can have a severe reaction to protamine. So it's better to ask for, if they are using an insulin, what is the brand, and if they have a fish allergy, prior vasectomy and all, they can actually react to protamine. And in case if they have a history of genital atrophy or iodine or shellfish allergy, they may react to contrast agent also. So all those things we have to keep it in mind. These are the general concerns. And what is that specific concern in case if the patient is having a poor GCS, and GCS being less than 8, or if they are mechanically ventilated, it is better to note their ventilatory setting so that the same settings can be used in the INR suite. And also, if sometimes these patients are on EVD, so you will, if we don't pay attention to EVD, it's external ventricular drainage. In case if the EVD is kept it in certain height, you have to note the height. What is the amount of CSF draining in particular hour? Is it continuous drainage or it is an intermittent drainage? All those things are very small things, but if we don't take care of it properly, actually it can cause severe complications. Patients can actually have a intraventricular hemorrhage if it is too much lowered, excessive CSF drainage, and that itself actually kill the patient. And also we have to evaluate them as a disease-specific condition in subarachnoid hemorrhage, AV malformation, dural AV fistula, carotid stenting, and all the carotid occlusion. In each procedure, they have a systemic problems. In each problems have to be assessed. We'll see detail about all those things in next slides. And now we have seen how we have to prepare the patient. Now, how are we going to prepare the endovascular suit, and what are the monitoring are we going to use? See, this actually we'll be standing actually very well away from the thing, and the C-arm will be keep moving. So all the intravenous line should have a sufficient slack, so that when it is moving around, the lines won't get caught in the C-arm and it won't get dislodged. And if at all, if the patient is needing the inotropic support or any vasopressor, that extension has to be pre-filled and it has to be connected very close to the patient. And otherwise, long dead space is there, it can actually end up in having a lot of problems. And coming to monitoring, we do all ASA standard monitoring, including ECG, SpO2, NABP, ETCO2, agent analyzer. How we are doing it intraoperatively, the same thing has to be monitored in the endovascular suite also. Apart from that, we do sometimes, put the pulse oximeter, especially female patients, small femoral artery. So when they cannulate, they can actually have a limb ischemia. So sometimes if you have a second pulse oximeter, we can place it on the site of right side. If they are cannulating the right femoral artery, we can place a pulse oximeter on the right lower leg. And also, it is a must in certain cases, we have to have a invasive arterial pressure monitoring. This gives a tight control of blood pressure, and some of the procedures you need a very blood pressure manipulation is extremely needed. So for that purpose, you may need invasive arterial line or post procedure. For example, if the patient is undergoing an AVM surgery, AVM embolization, so post procedure strict BP control is needed. So though you may manage interop, post procedure these patients may need. So it is better to put that. But same thing, but if the patient comes with a stroke, patient already had an IV TPA, and you don't need to waste time on starting IV, starting an intraarterial line. So in that, you can actually request the radiologist to give the femoral side port of the femoral artery catheter that can be used. And some cases, especially the carotid occlusion, aneurysm coiling, SSCP can be instituted, and some EEG can be used in WADA test, and TCD, NIRS can be used in all the AVM surgeries, and when aneurysm coiling also. Now, when we move on, now we have actually prepared the suit. Now we move on to what type of anesthesia are we going to use in each procedure. So it is actually each topic itself, it's a big topic. So I'm just going to say, depending upon the procedure, we select the whether the patient needs general anesthesia or if the patient needs monitored anesthesia care. For example, if the patient undergoes carotid artery stenting, or if the patient has a good GCS is 15 or 14 and very cooperative, if the patient is undergoing an angioplasty for vasospasm, obviously we don't need to anesthetize the patient, and for carotid artery stenting, it's better to keep the patient very awake. So monitored anesthesia care will be the anesthesia of choice. For aneurysm coiling, large AVM embolization, or if the patient is undergoing tumor embolization, obviously these patients actually, the procedure takes 3 to 4 hours. And during the procedure, actually patient can move and can have problems. So those cases we select general anesthesia. And a stroke intervention, that is depending upon the patient's GCS and which vessel is involved, and what is the aspect score, what is the NIHS scale. Depending upon that, we will select whether it is GA is needed or monitored anesthesia care. And whenever there is a raised ICP, if you are suspecting, it's better to institute total intravenous anesthesia. And also, if you have to look at the medical condition of the patient, and if the patient is having an poor cardiovascular reserve, sometimes balanced anesthesia is a must. And depending upon the neurophysiological monitoring, we need to select anesthesia type. And also, some procedures you have to have a hemodynamic alteration, that we will discuss it in detail in next slides. And all patients, you try and extubate them so that you use a short acting agents like sevoflurane, propofol, remifentanil and fentanyl. And we don't have a remifentanil, but we can actually use propofol and fentanyl combination. In selected cases, you can use dexmedetomidine. And what is the advantage of general anesthesia? Obviously, all technically challenging procedures, coiling, flow divert, stent placement for aneurysm, or flow diverter if you are placing, or if we are doing embolizing the large AVM, all those things will take longer time. Lying in the DSA suit for long time is very uncomfortable and stressful. So actually, by giving GA, we are actually removing all the anxiety and stress from the patient. And also, we can actually get a high quality image. So patient is, whenever we need to have an apnea, we can actually create it if we are controlling the ventilation. And also, we can actually keep the hemodynamics very stable, and you can actually adjust the ventilation. You can actually titrate the pressure and ICP, everything we can actually manipulate when it compared to monitored anesthesia care. And whenever the complication can happen in the suit, if we are identifying rapidly, you don't need to waste time on converting into GA. If you are actually already selected monitored anesthesia care, this is already there. So quickly you can actually start doing the steps of a procedure which needs to be done, and patient can be taken to theater if it is needed. And it is very comfortable for the both neurointensivist and neuroanesthesiologist. And now we have actually seen how we preoperatively evaluate the patient, how we are going to prepare the patient in an INR suit, and what are the monitoring we do, and what are the type of anesthesia we have done. Everything we have seen. Now, 3 things we have to know. How do we manage anticoagulation? In which cases patient needs blood pressure management? Which cases you need deliberate hypotension? In which cases you need induced hypertension? And how do we manage the complication? There are many complications can happen. It may be a hemorrhagic, or it may be occlusive, or it can actually contrast-induced anaphylaxis can happen. There are late complications like contrast-induced nephropathy, and all those things happen. So how do we manage them? We will see one by one. Now, why we need anticoagulation in the INR suit? Because every vessel puncture is associated with tissue damage, and that can actually exposes the tissue factor, which triggers the coagulation. And any angioplasty, you're stretching the vessel wall, that itself exposes the tissue factor. Any guide wire, which can every time when it goes in, it can cause vessel wall damage, and that also will trigger the coagulation cascade. And always all the guide wire and contrast agents are thrombogenic, and if any atherosclerotic or the small coil, if it gets embolized, it can activate the coagulation. So anticoagulation is must in all INR suit. So how do we monitor? How do we go about it? We have to do a baseline activated coagulation time, that is ACT. You have to do, you have to document, and then once the before doing, we have to give heparin about 1 milligram per kilogram or 70 to 100 units per kilo, so that we can maintain the ACT 2 to 2.5 times the baseline. And every hour, this dose has to be repeated. Usually we give 20 units per kilo. Sometimes if it is not maintaining, you can go up to 40 units per kilo, so that the ACT is maintained up to 2 to 2.5 times. And some centers, in case small thromboembolic complication happens, they continue for 24 hours, so that major thromboembolic complications can be avoided. In some cases where you see the heparin resistance, the dose can be actually increased up to 500 units per kilo. And in patients with an antithrombin 3 deficiency, the heparin may not work, so you may need to give FFP, and then you have to give heparin. And how BP, now we'll move on to BP management. In some cases, you may need to provide deliberate hypotension. So what is deliberate hypotension? Whenever we are reducing the blood pressure 20 to 30% from the baseline, it is called deliberate hypotension. Why are we doing? This is mainly to slow the blood flow, especially in the cases of AVM. As you can see here, this is a huge AVM, cerebellar AVM, where or if there is actually this is a big tumor. This is the case where we have done it, and it's a small child also actually. So when you want to do the glue injection, if the tumor is very vascular or if the AVM is very high flow, if you don't actually reduce the flow, actually the glue can embolize into systemic circulation. So it is very important to prevent systemic embolization in high flow AVM, or it's a very vascular tumor cases. So how do we do it? We can actually use with the labetalol, esmolol, metoprolol, hydralazine. If we can achieve this hypotension by giving propofol, fentanyl, labetalol, it is better. Whenever it's possible, we should avoid GTN and sodium nitroprusside and calcium channel blocker, because these are cerebral vasodilator. It can actually increase the ICP in case of a patient with a raised ICP. But if possible, sometimes if it is not possible, we may need to use these agents to reduce it. And when do we need induced hypertension? And this is actually during the procedure, if they have noted that the patient is developing a vasospasm, or if the patient had a small embolic stroke, then you have to actually bring the blood pressure up. So what is induced hypertension? You're actually bringing the blood pressure from, you start with 10 to 20% increase, you can go up to 30 to 40% within the baseline. So if the blood pressure is 90 to start with, sometimes 90, but you have to bring it up to 110, 120 mean also to break the spasm or to increase the collaterals. So it is called induced hypertension. And what are the procedural complication you can expect? It can be a hemorrhagic, or it can be an occlusive, or it can be an allergic or mild allergic, or it can be an anaphylactic reaction. And post-procedural, especially in an AVM embolization, there is an entity called normal perfusion breakthrough syndrome, because these arterial feeders are directly draining into the vein. The vessels surrounding the AVM are always, it's hypoperfused. Now, when we embolize these areas, the normal areas start to open up. These vessels never had a high flow through that. So that may actually initiate cerebral edema. So those things we have to keep it in mind, so that post-procedure, we actually keep the blood pressure strictly 10 to 20% from the baseline, will bring down and keep it. And that is very important. And also you can have a hemorrhage at the femoral puncture site. And so it can actually cause groin hematoma or retroperitoneal hematoma. And sometimes, late complications like contrast-induced nephropathy. So in case, if the patient develops hemorrhagic complication. As you can see here, this is the vertebral and then basilar. And as you can see here, there is actually, they are trying to coil the aneurysm here, but there is a extravasation is happening here. So if the patient is undergoing general anesthesia, you know that immediately patient will have a hypertension and bradycardia. Cushing's reflex will be there, and you will see in the screen there is a contrast extravasation will be there. So immediately the neurointerventional radiologist should tell the anesthetist. But if we are actually keep on looking at the field, it's very important. So you have to discuss with them immediately. You try and reverse the heparin using protamine. What is the ratio we use? 1:1. So 1 milligram of protamine for every 100 units of heparin. And whatever the blood pressure just before the incident happened, from that you have to try and reduce the blood pressure to 20 to 30%, so that the hemorrhage won't increase. And the interventionist, they will try and seal the leak with more coils. If it is not controllable, then you have to inform the neurosurgeon. You assess the pupillary size, asymmetry, reaction, and give head and elevation, start osmotherapy. And sometimes you have to give burst suppression in terms of you use a propofol for that, and while maintaining the blood pressure. See, when the blood pressure, when there is a hemorrhage happening, ICP is extremely high. So when we give a propofol bolus, actually BP can come down. That can actually cause a cerebral ischemia. So you have to actually have a low dose of noradrenaline going while giving the burst suppression. And if it is possible, you have to put a EVD placement, and we have to, in case if this happens during the clipping, coiling, then you have to actually take the patient to the further clipping or decompression of the hematoma. And sometimes if they are not on any anticonvulsant, if hemorrhages happens into the cortical area, they may be prone for more seizures. So you may need to give an anticonvulsant dose. Most of the time, they will do the typing and cross-matching and ready. In case if it is not done, it has to be done. And as you, now we have actually managed the hemorrhagic complication. Now we will move on to embolic complication. So if the patient develops embolic complication, so the particular territory of the artery gets occluded. So patient actually we have to open up the pile circulation or circle of Willis through which the blood supply has to happen. So we have to induce a hypertension. So you start with 10 to 20% increase from baseline. You assess the the neurological status if they are awake, or if it is not, then you have to go up to 30 to 40% increase in BP from the baseline. And if it is, then you do if they usually they do angio. If it is a big thrombus, they may need to do a mechanical thrombectomy. And there are many antiplatelet agents. They use it. Antiplatelets and anticoagulants, which ranges from antiplatelets, direct and indirect, 10A inhibitors, direct thrombin inhibitors, and then fibrin-specific agents and non-fibrin-specific agents, and antithrombin 3 activation through heparin and low molecular weight heparin. Commonly used agents are heparin, and in case embolic complication happens, they usually load with aspirin or clopidogrel, or they will give 2B3A receptor blocker. Now we will move on to vasospasm. As you can see here, and when during the procedure, this is actually because of the vasospasm, there is no flow in the picture 1A. And after the they did angioplasty and they injected the intra-arterial milrinone or nicardipine, actually it has opened up, and you see the the brighter circulation compared to this. And as you can see here also, this MCA whole MCA territory has actually, that ACA territory, this area is not opened up. Here actually you can see that the whole territory of ACA and everything is open. So now there are various drugs actually is being used for this vasospasm. They can start with an angioplasty, or they can actually give drugs like nicardipine, nimodipine, milrinone, and everything we can do. And usually it will actually, there is a possibility of vessel wall rupture when we do a balloon angioplasty. So usually it is done for proximal arteries. You cannot do this to A1 and N1 beyond, because it's when you do that, it can actually leads to rupture of the vessel. Then once we finish the procedure, some of the thing we have to continue the management during the post procedure also. If the procedure goes very well, we usually extubate the patient, assess the neurological status and document, and we will observe them in neuro ICU. But if the patient is actually undergoing an AVM, ensure that to prevent normal perfusion breakthrough syndrome, you have to reduce the blood pressure 10 to 20% from the baseline. And obviously, if they develop a spasm or post-embolic stroke, embolic stroke, then you have to induce a hypertension, keep it maintained for 24 hours, and then keep assessing their neurological status frequently, and then do the necessary things. And in case if there is post-procedural edema, especially tumor embolization, especially the posterior fossa tumors, after you tumor embolize, actually they will actually have a severe cerebral edema. So you have to start anti-edema measures in case if they are actually planning for surgery the next day. If they're immediately embolizing and taking up, it is better. But if they are actually proceeding the next day, then you have to ensure that you extubate the patient, keep on assessing the neurological status. If it is worsening, you have to actually intubate and maintain the ICP, and then you have to start an anti-edema measures. And you have to, in that scenario, you can actually use a multimodal neuro monitoring techniques like TCD, cerebral oximetry, and radiological imaging and everything, and so that you can pick up the complications early and manage. And as you have seen, the other complication is contrast reaction. It is nowadays whatever their contrast they are using is iohexol. It's a non-ionic contrast. The very, very rare complication only happen. That is, incidence is about 1 in 10,000. So actually the reactions are very mild with these agents. And in case if it happens, then you have to it can actually start with mild allergic reaction, or it can end up in having a severe anaphylaxis. Then we have to manage it appropriately. In case if they have any atopy history and this thing, better to give them an antihistamine and steroids, and then do the procedure. Then another complication is contrast-induced nephropathy. That is, otherwise it's called nephrogenic systemic fibrosis. That is very commonly, very common cause for the renal failure. This is about up to 12% can happen. So who are all the patients who are at risk for this contrast-induced nephropathy? If they are actually more than 75 years, or if they are anemic or diabetic, or if they are having a congestive cardiac failure, or if they're having intra-procedural period, if they have a prolonged hypotension, or if you have given a volume of contrast is so high that it can actually lead to contrast-induced nephropathy, or if they're having a pre-existing pre-renal, mild renal dysfunction, or other nephrotoxic agents are administered, together, then these patients are actually more prone for nephrogenic systemic fibrosis. So there are many drugs are actually described in the literature, but one thing is maintaining the blood pressure and maintaining the adequate hydration is the key factor to prevent the complication. And the last one is radiation safety. We have to protect ourselves, because the direct radiation can come from the X-ray tube, or it can leak from the collimators, protective shielding, or it can be actually reflected from the patient's body itself. So as you stay away from the field, it is better, so that your exposure is better. Better to have a lead shield, means this kind of lead shield, so that we can stay with the lead apron, we can actually stay behind the lead shield. And as you all know that the DSA radiation has a more radiation emission compared to the fluoroscopy. So you have to protect yourself with lead aprons, thyroid shield, and whenever it's possible, if you have a glove, you should do it. And also cataract is very common with this continuous radiation exposure, so you have to have a even eye protection also. Better to have a TLD badge, so that you know how much radiation you are actually getting it. This is just the slide of, see, this interventional cerebral angiogram. This is about, which is equivalent to 300 to 500 times the chest X-ray. So it is very high radiation. You should, every anesthesiologist should aware of this and protect themselves. And just touch on pregnancy and neuroradiology. And usually the pregnant patients, either they can present with an aneurysmal rupture or AVM bleed. Most commonly, the AVM bleed is quite common in pregnancy. So your aim is to protect both mother and fetus, but whenever you are doing this, neuroradiology procedure in a pregnant patient, try and do any gadolinium free MRI, because it's actually this contrast causes fetal dehydration. So you have to do a fetal monitoring. In case if you are doing a fluoroscopy or DSA, you have to put a protective lead aprons between the patient and the table, and you have to reduce the fluoroscopy timing and image. Instead of doing 10 images, whenever it's possible, 3 or 4 images, then less exposure. And whenever they zoom in, actually the radiation exposure is very high, so they should try and avoid magnification, and they have to use a low pulse rate fluoroscopy. And if you are doing an interventional neuroradiology procedure for a pregnant lady which is in 3rd trimester, always do it in hybrid theater, so that in case if any problem, we can actually take her to theater for an LSCS. And always the recommended radiation exposure throughout the pregnancy is only 5 millisievert, and so you can actually, the patient can expose only 0.5 millisievert per month of pregnancy. And ma'am, if we have time, I will discuss these things in each. I have actually put it up as cerebral aneurysm and AVM and dural AV fistula, and what are the new procedures being done. And if we have time, we will discuss. Otherwise, I would like to stop, ma'am.
Kasturi, you can answer a question. Does she have time to cover these subjects? Kasturi?
Ma'am, I guess we can just sum it up now, so that, and come to it later if we can add on new aspects of coiling of an aneurysm later on. Is it okay?
Yeah.
If we can
that's a new things. Some things are which is actually they are doing that alone. I'll just tell you in 3 minutes time, and then I'll sum up, ma'am.
Sure, ma'am. Sure, ma'am.
Yeah. So the SAH has a very bad systemic effect. So everybody should understand the systemic effects, and you have to manage appropriately. So I'm not going into, and whenever the AVM comes, as I have already told, these AVMs actually, when you manage, you have to maintain moderate hypocapnia, so that the normal vessel gets vasoconstricted. So when we inject glue, the glue won't go into the normal vessels and cause ischemia. That is the main thing. And in huge AVM, sometimes you may, as an anesthetist, we need to provide deliberate hypotension or transient flow arrest. So how can we do that? Either we can by giving the adenosine, that is about 0.3 to 0.4 milligram. And if it is not working, you have to give an escalating doses. Next dose is 18, then 24 and 30. So like that we have to do, so that they can actually, that asystole time, they can inject the glue, so the glue can stay in the venous, the arterial phase. And if it goes into the venous phase, it can embolize, or it can actually causes hemorrhage. And what is the antidote is deriflin. You have to keep it on the table. And sometimes you have to put a defib paddles, so that, in case if, if the patient is having a, persistent bradycardia, we can actually transcutaneous pacing, we can use it. Or even if there is adenosine is not available, you can do a rapid ventricular pacing. That also will cause a transient flow arrest. And when it comes to dural AV fistula, we actually create a hypercapnia, so that the intracranial venous outflow, it drains into extracranial part, so that when we inject drugs, it won't go into the intracranial system and cause. So in AVM, we cause hyperventilation and cause hypocapnia. For dural AV fistula, we create a hypercapnia. That is the different things. And stroke itself, it's a big, it's a topic. So you have to keep it in mind that time is brain. So needle, door to needle time should be less than 60 minutes. And we all know that where we are working towards the penumbra area. So any patient who comes within 4.5 hours, you have to actually start IV TPA. If they are coming beyond that, you have to assess whether they have a large vessel stroke, then immediately they will come to us, so that, we need to be ready for the mechanical thrombectomy. So IV TPA is actually contraindicated when the blood pressure is more than 185, 110. So try and reduce it with, with the labetalol and infusion, nimodipine, hydralazine and everything. And you have to know that.
I'm interrupting you, ma'am. Dr. Ramamani, sorry,
Yes.
can you just wind it up because we have 2 more sessions?
Yes, ma'am. Yes, ma'am. That's why I just summarize. So
Right.
there are now
Thank
newer
you.
interventional radiology procedures. Also, many are done for even for chronic subdural hematoma. And the carotid artery stenting is also done. This is another new procedures, that is the venous stenting. That is also we need to have some understanding. And another, I just wanted to summarize saying, each procedure has an disease specific management we need to understand. So for that, each anatomy and pathophysiology of each disease we need to understand. And in during the procedure, constant vigilance, and you have to identify the complication and treat it so that the neurological outcome is much better. Sorry for the exceeding, ma'am. Thank you.
Thank you so much, ma'am, for your extensive and informative presentation. I would request Madam Professor Dr. Amna Goswami to give a valuable inputs on this topic before we take questions from the chat box.
Thank you, Kasturi. Ramamani, it was a wonderful exposition.
Yes.
Very, very vast subject, and I think you have done justice to it, especially by stressing on the coagulation profile, where you have a tightrope walking and the control of the blood pressure. These are 2 things which I think need a very, very, very precision control, and also specifying on our own safety. I will not extend the time, and if Kasturi allows, can we have questions, Kasturi?
Yes, ma'am, we can have, but there are none in the chat box now as far as I can see. There's no questions in the chat box as of now.
So if there are no questions, I'll ask Ramamani one thing. Are you supplied with these monitors for the radiation when you're working in this neuroendovascular suit?
Are you using a TLD? What are you, ma'am? Or sorry, ma'am, come again, ma'am.
Monitors for radiation.
With these monitors when you're working in the endovascular suit?
Yes, ma'am.
These monitors which you put on yourself to...
Yes, ma'am. We use everything, including TLD badge. Yes, ma'am.
You are.
But the gloves, we don't use it, but neck collars, lead aprons, and the lead shield will be there. And we are using, yes, ma'am. And not the gloves and TLD badge.
What about the specs? What about the specs?
Specs, no, sir. Sorry, I forgot that. Specs also we are not using it.
So you don't use specs. You don't use gloves.
Yes, yes, sir.
So how much is the risk? That is very important for the anesthetist. Forget about the patient. For the anesthetist, how much risk do we put ourselves in?
Yes, sir. So that is inverse square law. If we actually stay 1 meter away from the area, with wearing of all these aprons behind the lead, actually its exposure is very less, because if you stay close to the X-ray tubing and the collimator, then it's actually high exposure. If you stay away with these devices and behind the lead screen, actually very minimal exposure.
You see, the problem is not only in neuroradiological procedures, the problem is in gastro, in cardio, all wherever the ortho, wherever these CR radiation is there.
Yes, sir.
So is there something that we can say about, say, if you stay away from the CR for 1 meter?
Yes, sir. We have to stay 1 meter away.
If the exposure is 300, because when the exposure is 300, then the machine will give you a ring. So is there something that after that you should wait for some time, or you should not repeat it, or anything like that? Is there anything
actually,
like
I have not come across anything, but they say that 1 meter away, and if you have wearing all the lead apron and staying behind the lead screen, actually very minimal exposure. Actually, if you protect with all
very minimal is not
okay, sir. I have not actually come across the thing, but they have actually.
Listen to me, because these are very important things. And should
actually, I could not.
Should the same anesthetist continue with the second, third, fourth case if there are so many in the list, or it should be alternately doing or something like that? I myself not aware about it.
That is why better to have a TLD batch, no, sir. If they have a TLD batch, and if we work 1 week, and then we can actually assess our own exposure, how much we exposed.
Madam, these days badges are not available because they say that the radiation is very low.
Yes, but if it is there, we'll be able to.
Say 10 years back, 20 years back. Is there anybody who can guide us on it? Is there anybody who can guide us on it? Madam Indrani, can you guide us?
Sir, we also have a DSA suite. We have, in fact, one in Neuro OT, and we have a separate DSA suite from the radiology department. All of them are doing neurointerventional procedures. And actually speaking, we don't keep the same anesthesiologist throughout the year. They are rotating like every month. One senior anesthesiologist is there, who is kind of there for 6 months. So what at least in KEM, I'm only talking for KEM, I'm not talking for any other hospital. So we have one anesthesiologist, senior anesthesiologist there for 6 months. And as she said, if you stay 1 meter away from there, and probably the exposure is less. And even in KEM, BARC is giving us badges, sir. So I think whoever is working for more than, for a kind of, working in the DSA suite for a long time should wear the badge. Never without the badge. So at least, you know exactly how much is your exposure. So that is mandatory if you're staying there. It's not that you should not work continuously. You can work continuously with monitoring.
What is the limit? What is the limit? That badge, when does we have to send it to the company to assess?
Yes, sir. Yes, sir. It goes every 6 months. I think it goes to BARC.
So that means for 6 months you can continue like this.
You can continue because this exposure is minimal, sir. Exposure is minimal. Actually, if you see the cardiologist, because a busy cardiologist will be exposed much higher.
Cardiologist, gastroenterologist, orthopedician,
they will get exposed much higher compared to anesthesiologists.
Can I share?
If you have a busy cardiologist, they will be exposed much higher.
And there are some surgeons or physicians who are crazy about getting exposed repeatedly.
That is problem. You can't help people who don't want to help themselves.
But there are no specific guidelines. There are no specific international guidelines.
No, sir. There are no guidelines except for the fact that you get monitored every time.
Put the base and monitor it and send it after 6 months.
Yes, sir. Because the exposure is less. That's all. If it is a heavy exposure, then probably the monitoring will be much faster or much earlier. But because the exposure is not all that much, so that is why.
Thank you.
Chairpersons, can I share?
Yes, sir.
Can I say something?
Yes, ma'am, please. Yes, ma'am. Yes, ma'am. Sorry.
In our center, I always post one anesthetist for 1 month in that suit, the radio intervention suit. And all of them, as Ramamani said, that if you have a TLD badge and you give a safe distance, and only specs they are not having, and the gloves they are not having. But others, we also do the same thing. And the TLD badges will just show that how much exposure you have. So timely, it is changed. The TLD badges are changed. Even if you do for this pain management, I do. I have a TLD badge and all these things I have. So these are the practice. What Ramamani said, that we have to practice this. And if you wear this TLD badge, then you can have the exposure, how much exposure you have. So that is. Thank you.
I have, madam, one suggestion.
Yeah.
The administrators should take care of young girls and ladies in the reproductive age.
Yeah.
Kindly take care of them. Don't put them in such suites when they are in the reproductive age.
Yeah.
This is my suggestion and my request.
All the MD students are all in their reproductive age. So only thing is we give them a proper lead apron. We don't let them in without that. And we take care that, that they are posted only for 1 month. And only one senior is there, and the professor, of course, is supervising everywhere. So a professor is not stationed right inside all the time. So one senior is there for 6 months. So they all are nicely protected, sir.
Right.
Thank you.
Now, please, end of the session. Thank you, Ramamani, for your wonderful.
Very nice, very nice.
Ma'am,
I'd like to take this up. See, Ramamani, you gave a wonderful,
Thank you.
wholesome, look into this neurointerventional procedure. Fantastic. Really loved your presentation.
Very, very
And,
nice presentation and very specific and to the point.
Very nice.
Thank you. Thank you, ma'am.
Excellent presentation.
Thank you, sir.
Dr. Ramamani, I'm sorry, there is one question in the chat box. I'm not getting the question, whether I'm getting the question correctly. Madam Upasana Naskar, she wants to know about MMA embolization in chronic SDH.
Yes, ma'am.
Any specific?
Actually, ma'am, I'm not able to see the question, ma'am. If you can just read the question, I can just answer, ma'am.
It's just written, ma'am, about MMA embolization in chronic SDH. Any specific cases? So I am.
No, ma'am, actually it is
specific cases of MMA
yeah.
embolization.
So any patient who are very high risk for surgery, actually now they are doing MMA embolization, because when you do, and when you extremely high risk patient, because they can't tolerate surgery, they are doing that. So this is mainly this MMA embolization is work by reducing the new angiogenesis. So new vessels won't produce and it won't cause bleeding. So that is why they are doing. And actually there's a lot of things there. And if they are coming with recurrent subdural hematoma, they are actually, so any patient who are having a high risk, for surgery, or if they are having a recurrent subdural, you can't keep on going and evacuating. For that, you are actually preventing an angiogenesis by causing a middle meningeal artery embolization. So that these two group, actually it is beneficial.
Thank you. Thank you so much. Thank you.
Thank you.
Thank you, Dr. Ramamani. It was such a brilliant presentation. Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, Dr. Professor Amna, madam. Thank you very much. Thank you, Renu, madam, for being with us on this session. So we move on to the next session. Right. So the next session, the next topic is implications, preventions, and management of post-operative cognitive dysfunction. While with the significant increase in life expectancies, along with recent advances in surgical managements and intensive care techniques, a large number of elderly patients are now, with lots of multiple comorbidities, are now posted for surgical procedures. And I'm sure most of us will come across such elderly individuals with lots of medicines, a few of them already on antipsychotics, antidepressive medications, and a significant percentage of these elderly individuals experience a transient post-operative delirium or a long-term post-operative cognitive dysfunction, commonly called POCD. Following any surgery, even a daycare procedure can incite such a phenomena. And the most, unfortunately, a notable fraction of them may land up with permanent dysfunction. So we are pleased to have with us Dr. Parthasarathy Goswami, a brilliant speaker for this evolving topic. And the chairpersons, Dr. Vibhu Kalyani Das and Dr. Ankur Khandelwal. Professor Dr. Vibhu Kalyani Das, well, madam needs no introduction, a teacher par excellence, a renowned academician, and madam presently holds the chair of Director Academics, Head of Department of Anesthesia, Critical Care and Pain, Institute of Neurosciences, Kolkata. She was the former HOD, Anesthesia, Neuro ICU and Pain Clinic in Bangalore Institute of Neurology, Kolkata. And the list of her achievements and accomplishments are absolutely endless. Thank you, ma'am, for accepting our invitation. We are extremely pleased to have with us Dr. Ankur Khandelwal with us today. He is presently attached as a consultant neuroanesthesiologist and neurocritical care specialist in Neurosciences Center, Hayat Super Speciality Hospital, Guwahati. We would be eager to get his insights on this topic too. Welcome on board, sir. I would like to request you to kindly introduce our speaker, Dr. Partho Sarathi Goswami. Dr. Ankur Khandelwal, please.
Yeah, good evening, everyone, and thank you, RSACP, for this opportunity. I'm extremely pleased to have renowned faculties, Amna ma'am, Vibhu Kalyani Das ma'am, and all my faculties out here. It's my pleasure to introduce you to Dr. Partho Sarathi Goswami, sir. He is a consultant neuroanesthesiologist at Park Sciences, Neurosciences Center in Kolkata. He has been practicing neuroanesthesia for almost the last 2 decades and general intensive care for the last 2 decades and 2 years. So it's an extremely pleasure to welcome to you on board, Partho Sarathi, sir. May you begin your topic, sir. Dr. Goswami, sir.
Unmute yourself, Partho.
We are not yet able to see your slides. Yes, probably.
Yeah, can you see me?
Yes, sir.
We can see you, yes. Not your slides yet.
Yeah, I think you can. Oh.
Sir,
Can you see me?
yes, sir. It's
Yes.
visible now.
Yeah, good evening, ladies and gentlemen. This is Dr. Partho Sarathi Goswami from the Park Neurosciences Center in Kolkata. And it's a very warm and balmy evening here in Kolkata, actually. And I'm actually stuck between people with reproductive challenges from the neuroradiology suite and somebody with a broken neck who, unless fixed, will probably die. And here I am to talk about the impact of general anesthesia on cognitive impairment, which is extremely controversial and complex. The reason why I tell you that is, as we go along, we have to understand the fundamental difference between what is the thought process that goes on in our brain. And ladies and gentlemen, it suffices to say that even in 2022, we have a very scant understanding of how the brain functions, save and except that we use probably only 10% of it during the lifetime. And what is the fundamental difference between thought and cognition? Well, according to Merriam-Webster dictionary, which was published last year as, I think, 151st outward.
Slideshow. Can you put it full screen, Dr. Goswami, please? Can you put your slides full screen?
I think I am.
No, we are not getting it as slideshow yet.
Slideshow, make it slideshow.
Where is the slideshow?
There's a button immediately left to the 48% on the lower bottom, please. Right lower bottom, sir.
Wait, just 1 second. Just let me.
There is written 48%.
Yeah, just 1 second. I go to Zoom cloud meetings, right?
No, sir. Open up your PPT. Yes, button.
Beside that.
Yes, this
one.
button.
Yeah, but yeah.
Right. Cup.
Right, go right. Yes, down, left.
Yeah. No, I don't think I'm able to see this actually.
Yes, you are able to see this. We can see this.
Where is this? Here?
So there is a button immediately left to the 48% written there.
Oh, there is a button here.
Yeah, on the left side of 48%. Left side of 48%.
Up to left now. Just left. 48%.
Yeah.
Yes.
I know.
Yes, please.
Can you see me?
No, हुआ नहीं अभी तक. Click on it.
I have clicked on it. I am able to see it full screen.
Okay, please go ahead, sir. Please go ahead. We would be able to.
No
Please go ahead, sir.
Yes, it says your screen sharing is paused, but can you see the slides?
We can, Dr. Goswami.
But is it? It is smaller, is it?
Yeah. Yes, sir. We can see.
What I can do is I can increase the size of the slides, and then we can. Oh, has the size increased?
Have you put it in slideshow? Have you put it in slideshow?
No, actually,
Yeah.
Actually, his slides are
Yes.
yes.
Yes, this is okay,
We
sir.
have got
It is
it.
done,
We have
sir.
got it now.
It's much better now.
Much better now.
Please go ahead, sir.
Please.
All right. So we are talking about the fundamental difference between cognition and thinking. So if you are thinking aloud, then you are probably having cognition about what is happening. So when we define cognition, it's not just simply the act of thinking. It's the process of acquiring a piece of knowledge, understanding through thought, all the experience that you have, and finally you apply your senses to come to a conclusion. Which means, like this gentleman to the right of your picture who's keeping on thinking and having proper cognitive senses, you're not only doing something very simple, you're using the whole of the brain to have attention, to pay thought to it, perception, use your memory, your fundamental concepts of language, learning, communication, and finally analyze what has been said to you. And this, ladies and gentlemen, as apparent as it may seem to be simple, is one of the most complex things that humans have evolved over their period of evolution since centuries and millennia. And the first article, which came out for postoperative cognitive dysfunction, which is again a concept in evolution, is not new. It is as old or as antiquated as the evolution of anesthesia itself. And the first article which came out was in the British Medical Journal way back in 1887, which had a fantastic term saying insanity following the use of anesthetics in operation. And this was the time when people were just beginning to use chloroform or ether for anesthetics. And since then, we've moved on, and we have now begun to realize that as an aging population, a new cognitive impairment after a surgical procedure is termed as a cognitive decline. So before surgery, there can be a neurocognitive disorder. And since this is a seminar on neuroanesthesia, we have a significant number of people who already have certain amount of neurocognitive decline or damage. Within 7 days, we can have postoperative delirium. Within a period of a month, you have delayed neurocognitive recovery. And within 12 months, we can actually stamp it as neurocognitive disorder. So how frequent is this? According to the most frequently available literature, young people have a lesser incidence, but still 36.6% of patients when probed between the age of 18 to 39, 30.4% between 40 and 59, and 41.4% who are aged above the age of 60 will have a new onset cognitive decline after a major surgical procedure, including complex anesthesia. So looking back at what happens, the field of play, we've come to realize, and this is again an evolving science, something which we are learning by the hour, by the day, by the minute, is the blood-brain barrier. And it's a fundamental problem. The genesis of the problem is inflammation. Anesthesia, steroid surgery, individual susceptibility, and genetic predisposition all combine together to provide the substrate for POCD. So inflammation is the fundamental cause. You have an activation of the systemic inflammatory response syndrome. If your cognitive reserves are low, you have a tremendous amount of inflammation after the whole procedure. And this sets into motion what I fundamentally call the headbanger's ball. The blood-brain barrier keeps the brain protected against multiple insults. But once the tight junctions of the blood-brain barrier begin to fall apart, it sets into motion agents like high mobility grade proteins, tumor necrosis factor alpha, interleukin 6, interleukin 1, and they all cause neuroinflammation. And this is slowly but surely translated into a delayed post-operative cognitive dysfunction. Now, as this is new science, as this is science which has completely not been defined, I called POCD a complete chimera of entities. And like this picture, it can be a lion, it can be a ram, or it can be a snake in the different view that you see it. And as you can see, there are multiple terminologies which have been used as far as the temporal sequence is concerned as PND, postoperative cognitive dysfunction, neurocognitive disorder, delayed neurocognitive recovery, and finally postoperative delirium, which tells you very, very clearly that we don't have exactly a defined term. It's as hazy can be. So what are the timelines, what we are talking about? As far as POCD is concerned, if I were to put my money and to when to test, I would probably not do it within a week. I will probably do it at a week, maybe 2 weeks, maybe a month. And how many of our patients actually come back for a testing after 6 months or a year? Almost none. And therefore, the determination of postoperative neurocognitive disorders, ladies and gentlemen, remains an enigma, particularly in the Indian setup. We can talk about this, we can discuss this, we can debate this, we can thrash out point after point. But the fundamental point which remains to be seen is how many of the patients ultimately come back to a neuroanesthesiologist for a cognitive assessment. The answer is very few. So the bedside practicals which I want to stress across to my juniors as well as my colleagues: do not test for POCD unless 7 days of the surgery are over, because there is too many factors which come into play within the first 7 days, including a tremendous amount of a cytokine storm which happens after surgery. And only beyond that are you talking business on POCD. So the testing parameters on which POCD can be judged, including learning, memory, language, perception, social cognition, where the patients can actually recognize relatives, distant relatives, near relatives, complex attention, paying attention to a newspaper, assimilating that information, and finally, whether they can translate that into practice. What do we use? We use a mini mental score examination, an abbreviated mental score, the Montreal Cognitive Assessment. And what is very, very important to realize in this field of science is that you need a pre-op assessment and a post-op score on at least 2 sets of data. Another open question: how many of us actually do assessment of neurocognitive results before we gas the patient? The answer is very few. It's the neurosurgical team which will give you a GCS score at its scratchy best, but that is about it. And if you're operating upon somebody with a brain tumor, maybe a mini mental score examination, but that's about it. But are we really testing cognition? The answer, ladies and gentlemen, is no. Having said that, once we have tested pre and post-op, what are the ballpark figures we are looking at? If it's more than 1 to 2 SD, we have mild POCD. And if it's more than 2 standard deviations from your baseline test, which is pre-op testing, we can easily call it post-operative major neurocognitive disorder. So what are the risk factors for POCD? And I've intentionally highlighted those which have solid scientific foundation, those which have scientific basis, age above 65, a history of cerebrovascular accident with no neuroresidual improvement, duration and the type of surgery. And when we are talking of neurosurgery, the average time for a major neurosurgical operation would vary somewhere between 3 to 4 hours. And therefore, we are looking at a huge burden at risk of development of cognitive disorders. Pre-existing cognitive impairment, those patients who have postoperative respiratory dysfunctions, and that will be a sizable ballpark figure for you. Postoperative infections, that should be minimal. And this is something, again, which is very, very interesting, is time spent with a bispectral index score of less than 40. This is a very controversial area of research, but that is what the literature is saying as of till now. So there are certain special problems in neurosurgical patients vis-a-vis orthopedic surgical patients or patients coming in for general surgery. And when you're operating upon patients like this, you expect, you anticipate that these patients will already have some sort of neurocognitive defect. With a size of a ball, this tumor is definitely going to have an impact upon the brain. With patients like this, with a midline shift, half the brain flattened out, there's complete loss of sulci and gyri and a chronic subdural hematoma, 60, 81-year-old on the table, you have a problem on your hands. This sort of a tumor on the frontal lobe, you expect neurocognitive deficits even before the patient is put to the table. And these are patients which you will operate day in, day out. And this is obviously somebody who's undergoing a decompressive craniotomy. This is somebody who came in with a GCS score of approximately 8/15, underwent a decompressive, and then obviously went on to develop a very slow neurologic recovery. And as far as surgeries on the spine are concerned, when you're taking these people up, the average duration of surgery will be somewhere to the tune of 3 to 4 hours, or even more. And if you're doing that, the fundamental problems, the red flags which creep up are preoperative neurodeficits, patients with altered mental states. So testing becomes very difficult. Multiple medications that act on the central nervous system and the peripheral nervous system. And that is your area of interest. So you essentially have a conflict of interest. Prolonged surgical times, at risk of development of secondary neurologic insults during the course of surgeries, a very high incidence of postoperative respiratory complications, particularly for high cervical spine patients. So these patient problems in the neurosurgical patient will hinder the research as far as POCD is concerned. And as far as the treatment and prevention is concerned, Benjamin Franklin talked about this many, many years ago and said that an ounce of prevention is worth more than a pound in cure. So these things can be followed in sequence to reduce the incidence of postoperative cognitive decline. And I would use this forum to at least make sure that some of us do a testing of the cognitive reserve through a basic test before we put patients up on the table. These are days of medical legal litigation, and therefore it becomes of paramount importance that this test is also incorporated into the pre-anesthetic assessment, including airway assessment and systems assessment of other systems. We avoid or reduce alcohol intake, optimization of diabetes mellitus, ischemic heart disease, treatment of atrial fibrillation, the reason being that microembolic strokes can actually lead to development of postoperative neurocognitive decline, and the concept of prehabilitation, not rehabilitation, but prehabilitation for complex surgery is also evolving. We're looking at minimally invasive surgery, monitoring of the central nervous system during surgery itself, We have to play around with the anesthetic agents that we have, ball-directed fluid therapy, and the avoidance of secondary CNS injury. And these are things which are within our control. And this is something which we can discuss and debate about. There's a decreased risk for agents and there's an increased risk for agents. And we now see that EEG guided anesthesia or BIS guided anesthesia is a wonderful thing to have. We are increasingly becoming dependent upon dexmedetomidine as we discover its multifarious activities. Propofol, ketamine, and non-steroidals like the coxids have been found to decrease the risk of POCD vis-a-vis other agents like the benzodiazepines, the duration of anesthesia, and the postoperative infections which have been found to increase the risk of POCD. We have now come to realize that as much as we discuss and debate and trash about the points, the roles of general anesthetic as far as POCD is concerned will probably never be certainly elucidated because we have conflicting data as of till now. And it's the hippocampus of the brain which is the seat of learning. The role of general anesthetics and the mechanisms of hippocampal and extrahippocampal dysfunctions in the genesis of postoperative cognitive dysfunction. So people across the world are beginning to pinpoint on an area where we can finally lead the way. What can we do in the postoperative period? We can use multimodal analgesia, reduce the amount of opioids that we use, ensure that the brain gets an adequate amount of glucose, not too high, not too low, postoperative mobilization, and finally, enriched environment. I want to introduce this term. By enriched environment, we mean an environment in which the recovering patient is close to as a home environment as possible. And that has been shown to biochemically affect the brain, to increase the amounts of dopamine or pleasure-giving substance in the brain. And that can actually decrease postoperative cognitive dysfunction. So do we have a magic bullet for POCD? The answer, ladies and gentlemen, is no. So how can we get around the issue? What's the practical things that we can learn from this? As I have told before, and I want to re-emphasize, let preoperative neurodeficits be documented in the preoperative period in detail. We have to assess cognitive reserve beyond the Glasgow Coma score. We have to ask what levels of cognition patients have, assess social support systems, give them consent about the possibility of POCD at risk cases, explain to them the surgical options of surgery versus no surgery, risk versus no risk, elevated risk versus low risk. And what we can do at our end is optimize medical status. Use depth of anesthesia monitoring. Try to keep the BIS between 40 and 60. That's the only thing which has been documented. Make sure that hyperinflammation as a cause of ill-treated pain does not happen. Continue pertinent medications in the preoperative and the postoperative period if the patient is already on them, agents that will sort of slow down the neurocognitive decline. And of course, avoid high-risk medications. These are things which are within our control. Is the treatment of POCD possible? I never thought that this would ever turn up because Benjamin Franklin told us very clearly that if we prevent, then we don't have to treat. Enriched environment, make sure that the family is very much involved in the process of treatment rather than keeping them out of the ICU and out of bounds. Cognitive training, physical exercises or early mobilization, and finally nutritional augmentation. And as far as the pharmacological manipulation is concerned, people have used these agents to varying success: haloperidol, ziprasidone, melatonin, which is the natural sleep hormone, ramelteon, and finally rivastigmine. But ladies and gentlemen, as much as they have been used, once the damage is done, nothing more can replace a damaged neuron. So our job today is to make sure that we prevent the problem rather than treat the problem. And as of 2022, nothing can be more pertinent without touching this. We have a completely new angle to the problem. COVID-19 has become a novel risk factor for the development of perioperative neurocognitive disorders. We've increasingly begun to realize over time that COVID not only affects the lungs, it affects the central nervous system as badly as it affects the alveolar system. How does it do? And we have now learned over a passage of time, and unfortunately this paper actually came from China, but the elucidation is fantastic. It causes hippocampal injury. That little structure in the brain, which makes us think, which gives us a sense of cognition, which gives us a sense of being a human individual. And the COVID-19 virus even manages to damage the hippocampus. So as much as we look at long COVID patients, a significant number of them will have preoperative neurocognitive disorders. A fragment of them will ultimately land up on the surgical tables across the world. And therefore, it becomes even more of paramount importance that we document preoperative neurodeficits before we anesthetize them. So what can we brood on in the evening ahead? We have now begun to realize that POCD is a definition in evolution. The blood-brain barrier is the key site of action. Neuroinflammation is the key mechanism behind POCD. There are certain key players with fancy names. What is within our control is we can test preoperative neurocognitive deficits and refine our anesthetic techniques with agents that have solid scientific evidence so that we can reduce POCD. And prevention, according to the old adage, is the key treatment. We really do not know which way we are going. Many, many years ago, Virgil, in his ecologues, said, "Omnia fat etis animum," which means time robs us of everything, including our memory. We are an aging population. The brain will invariably grow into a downward spiral as we age. We will forget. We will forget our memories of youth, of songs of happiness, of words of encouragement. Let not surgery and anesthesia add to this natural process of neurocognitive decline by adding to the problem of postoperative cognitive dysfunction. Thank you very much for your time, your enthusiasm, and listening to an area of intense research and intense uncertainty in neuroanesthesia and neurocritical care. Your suggestions, your valuable comments, and of course your brickbats are welcome at my email address. Best wishes for a fantastic evening ahead. Thank you very much.
Thank you, Dr. Goswami. As always, a very crisp, compact presentation with your wit and knowledge. Perfect blend. Thank you so much. I would request Professor Bibhu Kalyani Das to put forth her opinions and thoughts on this topic before we move on to the next session. Madam, please.
Thank you, Kasturi. And actually, it's an excellent presentation by Parthu, as usual. Can you hear me?
Yes,
yeah, we are all here.
You can. Yes, ma'am.
Excellent presentation. So he touched everything, like the pathophysiology, what happens also. And it is, as he mentioned, that it is the inflammatory stress, as well as the changes in the blood-brain barrier, the endothelial lining. And these are the important factors. And also, he has also emphasized on the hippocampus And also the hypothalamus also is very important. If there is any involvement in cases of stroke, if the thalamus, the thalamic area, the hippocampal area, and the white matter, if they are deranged and there are changes, white matter changes are there. So these people are more susceptible to have this cognitive decline. And as he has already stressed that cognitive dysfunction and disorder, how you go for. If it is more than a year, then you can call it as a disorder. Otherwise, in 7 days to 1 month, you can dysfunction. So these are things that he has already mentioned, and how to tackle that. Counseling the patient and having that the scoring system of the neurocognitive tests preoperatively in susceptible people, who are aged people, who are on multiple drugs and comorbidities, and also who are going for the second time, third time operations. All these people, you have to go for this the cognitive function test, and you are judiciously use drugs, whatever you are, what are the drugs which are basically not have that effect. And this monitoring, of course, he also mentioned about 40 to 60. Within that, you have to keep the peace monitoring, and you monitor also peace. Thank you very much. And if anybody has any question or anything, and Ankur also, Ankur, if you want to say something.
Thank you, ma'am, and thank you, Goswami sir, for this excellent presentation. I just have a few points. The last 10 years have been extensive research on these three very important topics: the neuroinflammation, the anesthesia, and the developing brains, particularly the PANDA trial, the GAS trial, the MAS trial in children, and the anesthesia and post-operative cognitive dysfunctions. So everything well placed in slides. Important points, yes, pre-operatively document, and the recent concept of pre-rehabilitation, whether it's be optimizing the comorbidities or cutting down the level of alcohol, cessation of alcohol, cessation of smoking in the pre-operative period. So optimization best in the pre-operatively as much as possible, correcting the hydration status, electrolyte status, and much is also dependent on the type of anesthesia. Yes, it's again a matter of discussion, regional anesthesia versus general anesthesia, though it is not much relevant in neurosurgical, but yes, when it comes to spine surgeries or in any other extracranial surgeries, general anesthesia has been linked to lesser incidence of POCD. Even in brain surgeries, we can cut down the amount of benzodiazepines or opioids by using scalp blocks. So regional anesthesia is again wherever possible should be used. Intraoperatively, much stress to be optimizing the perfusion, the oxygenation, the two most important things, blood pressure and oxygenation. Apart from this, hydration, electrolyte status, sugar levels, again, these are very important. And post-operatively, you have already mentioned close to family member as early as possible. Early mobilization is again very important. Good environment, minimizing the polypharmacies, and good control of pain in the post-operative period. That and reassurance, that is always most important.
One thing.
Thank you, Dr. Khandelwal. Thank you.
No, I want to say something that this regional and versus general, this is not established actually. There is no confirmative things that.
Can I add a point? As far as this debate is concerned, it's been observed that regional anesthesia and general anesthesia almost have the same incidence of post-operative cognitive dysfunction. We don't exactly know the reason why, but regional anesthesia with added sedation exactly an anesthetic.
I'm sorry, Dr. Goswami, I'm sorry to interrupt, but actually we have one more session to go. So once the session is done, can we get back to the discussion if the time permits?
All right.
I'm sorry, ma'am. I'm sorry, ma'am. Can we just move on? And the questions are there on the chat box. Can you, Dr. Goswami, can you please answer them on the chat box, please, if possible? There are 3 or 4 questions for you on the chat box.
I'll take the query to Goswami, sir, from the chat box.
Yeah, I can see what is written.
No, I was just suggesting that can we take up the questions after the next session is done? So
yeah, we will do that. We will do that.
Kasturi, please move on to the next session.
Yes,
please.
that's what we are doing, ma'am. Yes, thank you. Okay, so right, so our next session, we directly move on to the, we have a serious time constraint, so I'm sorry I had to interrupt in between. It's traumatic cervical spine injury, our approach as perioperative physicians, and it's a panel discussion, and as moderator, we have Dr. Indranil Ghosh, and for panelists, we have Dr. Ashish Bindra, Dr. Prakhar Ganesh, and Dr. Ranadhir Mitra. Well, Dr. Indranil Ghosh is a senior consultant neuroanesthesiologist and intensive care and palliative care specialist, presently attached in the Institute of Neurosciences, Kolkata. And he has passion and dedication for academics gets clearly reflected in the various faculty posts held by him. Thank you for being here with us today, Dr. Ghosh. And I would request you to introduce the respected panelists, Dr. Bindra, Dr. Ganesh, and Dr. Ranadhir Mitra.
Yeah, thank you, Dr. Kasturi, for that introduction. I'll straight away introduce the panelists of this session. The first panelist is Dr. Ashish Bindra, who is Additional Professor in Department of Neuroanesthesiology and Critical Care at All India Institute of Medical Sciences, New Delhi. And Madam's experience and clinical interest and expertise are particularly in targeted temperature management, neurotrauma and critical care, epilepsy anesthesia and chronic pain management. And she has got numerous publications to her name. Dr. Bindra, welcome. My next panelist is Dr. Prakhar Ganesh, who is working as a consultant neuroanesthesiology and neurocritical care at AMRI Hospitals, Dhakuria. He was earlier working in same capacity in Global Hospitals, Chennai. He has done his postdoctoral certificate course in neuroanesthesiology from Sichitra Institute, Trivandrum. And he has got special interest in neurocritical care and pain management, and also in medical law and ethics. My third panelist is Dr. Ranadhir Mitra, who is a consultant and head of neuroanesthesia and neurocritical care at Utkal Hospital, Bhubaneswar. He is a DM in neuroanesthesia and critical care from All India Institute of Medical Sciences, New Delhi, has written multiple papers in both national and international publications. For the last 6 years, he had been heading the neuro unit in first in Care Hospital and currently at Utkal Hospital. His main areas of interest being neuroprotection and neuro rehab. So welcome you all. Welcome all of you.
Thank you, sir. Very good evening to you and all respected speakers in the webinar and the seminar. It's really very good discussion going out, and with all comments from the senior faculty, they have been very enriching. And thanks for inviting me to speak on spinal cord injury as a panelist hosted by Dr. Indranil.
Okay, so I mean, as it is known by everybody that spinal cord injury, particularly cervical spinal cord injury due to trauma or due to any other causes, is a very big burden and a very big issue. And we as neuroanesthesiologists and neurointensivists are very much involved in managing patients with cervical spine injury, both in the ER, in the operation table, in the intensive care unit, and as well as in the management of pain, palliative care, so on and so forth. So we as the topic of this panel rightly mentions, that we are basically acting as perioperative physicians for patients who are unfortunately suffering from some form of cervical spine injury. So we will start the panel discussion right away with Dr. Bindra. So we would like to know, I mean, what are the effects of the spine, cervical spine injury on the various body systems? How a person's whole body is affected by injury to the cervical spine due to any cause?
Right, sir. So as a part of the ATLS, whenever we start looking at the patient, it's generally advised to go by ABCD guidelines. So I would like to talk the similar way. So if we encounter a patient with cervical spine injury in the ED or in the OR or in the ICUs, first is the airway, the one which is we are bothered for, and especially in patients with cervical spine injury, the airway is endangered. So when we say that it's endangered, that means one is protection of the airway along with the stabilization of the cervical spine. So in high cervical spinal cord injuries, the airway, one is because if it is a higher lesion more than above C3 level, then patient can have respiratory distress when you look at the patient. If it is a partial injury, maybe the patient may present with an intact respiration but may have a labored breathing, which can lead to hypercarbia and hypoxia, which can gradually lead to atelectasis. And because of poor cough in these patients of high cervical spine injury, gradually they are not able to clear the secretions, and there is impending airway failure in these patients. So first is the airway, and along with it, whenever we are dealing with it, there is the role of cervical spine stabilization, because these are the patients which can have instability of the fracture site, which is impinging on the spinal cord, and it can either lead to greater deterioration. So airway has to be seen along with cervical spine protection. Number two comes the breathing. So breathing is categorically affected in these patients, and we can see the lesions which are above the level of C3. They can present with complete respiratory failure. As so that if patients who have a higher cervical spine injury or coming with hangman's fracture, they may not come to you to the hospital and may have a respiratory arrest at the site only. The ones who are coming at the hospital can be divided, the ones above C3 where phrenic nerve is completely gone, and then there can be lesions from C3 to C5. These lesions can be complete or incomplete injuries, as in we can classify them according to the Asia spinal injury severity score, which can change them to A, B, and C, D patterns. Starting from complete injury in Asia A grade to incomplete or no spinal cord injury in Asia E grade. So Asia E has just maybe a skeletal abnormality, but no spinal cord abnormality. So these patients which are of higher cervical spine can have a respiratory failure, they can have impaired cough, they can have atelectasis, they can have pneumonia, and as the time progresses, either they have to be intubated at the spot, or they will require intubation later on, because the accessory muscles are not able to sustain for longer time. So if there is only diaphragmatic palsy, patient may use accessory muscles for some times, but sooner or later will require intubation and mechanical ventilation. And with increasing time, they can have respiratory failure and will require ventilation sooner or later. And the duration of the ventilation depends upon, again, the severity of injury. Complete spinal cord injury or the tetraplegics, they may require ventilation for probably lifelong. And as the duration of mechanical ventilation increases, so is the problems associated with mechanical ventilation, which may include ARDS, ventilator-associated pneumonias, requirement of cuff assist device, inability to cough, and a very difficult weaning. So this is problem with the breathing. Then we come to the circulation. So in circulation, these patients, it is classically said that these patients can have cardiovascular involvement if the lesion is above T6 levels, wherein the cardioaccelerator fibers, they are transected, and these patients have predominant parasympathetic tone, which may result in bradycardia and hypotension. Now, because of there can be a sudden or at the time of injury, there can be an intense sympathetic surge, which can lead to hypertension. Like when you are doing an intraoperative surgery and suddenly spinal cord gets injured, there can be immediate hypertension. But in patients with traumatic spine injury, maybe we are not able to see that immediate hypertension, which can be seen at the time of the injury immediately, and patient may turn to us later. What we encounter is generally a phase of hypotension along with bradycardia, which exists in about 65 to 75% of patients may present with bradycardia and hypotension in a similar number of patients, more so in patients with higher cervical spine injury. Now, this hypotension can be because of the neurogenic shock, which can be seen in patients with cervical spine injury. Neurogenic shock is because of the predominance of the parasympathetic fibers, and it is characterized by hypotension along with bradycardia, which is different from hypotension and tachycardia of hemorrhagic shock or the traumatic shock, which is commonly seen in patients with polytrauma. So if you have a patient with polytrauma, the patient can have hemorrhagic shock along with neurogenic shock in patients who have spinal cord injury along with polytrauma. In patients with alone spinal cord injury, it may be only the neurogenic shock. So when you are trying to treat this shock, you have to keep in mind that the neurogenic shock presents as hypotension and bradycardia. Patient generally has warm pink extremities and has a wide pulse pressure, which is different from the hemorrhagic shock. So in these cases, the management is using of the vasopressor agents. And fluid loading here becomes really tricky one, because in these patients, maybe the fluid overload can be seen if you give more fluid, and you have to be very cautious. And these patients can have this neurogenic pulmonary edema as well if you transfuse too much of fluid. Then the choice of the vasopressor depends upon the presentations, and generally it is the vasopressor which are required because below the level of the injury, the sympathetic surge is gone, which leads to predominant vasodilatation. Along with the flaccid muscle paralysis, there is pooling of the blood in the lower limbs, which are the major contributors to the development of the shock. So this is C. So while assessing the patient with cervical spine injury, you look for circulation. In circulation, there can be bradycardia, there can be hypotension. These patients may require inotropes, and especially the vasopressor agents. And here the question arises that which vasopressor is the drug of choice? Should we go for dopamine? Should we go for noradrenaline or pure vasoconstrictor like phenylephrine? So these are the drugs which are being used. So we have had a study done wherein we saw that inotropic support which was used at the institute was more commonly dopamine, and which was persistently used for more than 7 days in patients with cervical spine injury. Ideally, it is said within first 7 days, neurogenic shock subsides and requirement of vasopressors decreases. But here we saw that many patients require it beyond 7 days. So after coming to the C circulation part, we come to the D part, which is the disability part, which ranges like again we talked about ASIA grading of these patients, that we have to see the level of injury, and depending upon the level of injuries, various systems can be affected. Now after this acute or things, we have to look for other systems which can be involved in these patients, especially for the cardiovascular. As the injury proceeds, the patients may have orthostatic hypotension, which can be because of the venous pooling, and it is particularly common when there is postural change in these patients. So the management of orthostatic hypotension should also be considered in these patients. Other things which we need to look into these is the effect of spinal cord injury on the gastrointestinal system, and consideration of involvement of bladder and bowel in these patients. So if there is a complete spinal cord injury with sacral involvement, these patients are likely to suffer from bladder and bowel dysfunction, commonly known as neurogenic bladder and neurogenic bowel. Neurogenic bladder, therefore, means that patient doesn't have a control over the bladder, bladder in sense detrusor contractions are not possible and there is difficulty in voiding, which usually results in urinary retention. This urinary retention can result in stasis, formation of urinary stones, frequent UTIs in these patients, and is pretty worrisome. So generally in acute phase, these patients are kept catheterized. And if you have a patient which has a sacral sparing, which can be determined by looking at the spinal sensory levels, then please look for this whether the patient is able to perceive bladder sensations or not. Similarly, there can be a neurogenic bowel wherein there is lots of ileus and constipation in these patients, and because of this ileus and constipation, even the abdominal musculature is paralyzed, it is flaccid, and absence of the sacral reflexes results in constipation and bowel stool impaction and etc. Along with it, for the gastrointestinal, very commonly these patients, because of gastric atony, they can have reflux symptoms. They can have ulcers, especially the ones who are on steroids, if steroids are being given, which is another controversial topic, but still for prolonged ventilation, prolonged stay in the hospital, giving multiple antibiotic medications and various other medications put the patients to the risk of reflux, GI reflux, regurgitation, ulcers, and gastritis, which has to be taken care in these patients by formulating a very good bladder program, by good GI administration of antacids, intermittent feeding, by Ryle's tube aspirations whenever there is atony. So they have to be kept in mind. Similarly, for management of neurogenic bladder, a bladder program which consists of intermittent catheterizations and maintaining good hygiene is important. And clean intermittent catheterization usually helps in long term, but maybe in acute phases, it is the regular catheterization, which can be the one with the silicone catheter, which reduces the risk of catheterization, and rapid change of catheters should be done. Then we come to the immunomodulation. So immunomodulation, the sympathetic supply to the immunomodulator organ is also changed, which may lead to recurrent rapid infection in these patients. And moreover, stay of patient in ICU can cause various kind of infections, which include respiratory tract infections, which can be bloodstream infections, or it can be UTIs, which are pretty common in these patients. Moreover, these patients are quite dependent. They are on bed for longer time. So these patients tend to develop pressure sores also. For pressure sore management also, you have to make a good program in the ICU, wherein positioning of these patients should be done every 2 hourly, and padding should be done at the bony prominences. And if ever the pressure sores develop, they have to be dressed and debrided if required. Then we come to another important topic is effect of spinal cord injury on venous thromboembolism, or the on coagulation profile. These patients, because they are bedridden and they are on bed for long times, they have a very high propensity to develop deep venous thrombosis. So deep venous thrombosis has to be expected in these patients. And though it is very difficult sometimes to clinically see the deep venous thrombosis, but it is recommended that you should go for watching the local signs like arrhythmia, hyperemia, increase in temperature, or increase in the size of the diameter of the limb. And in all possible circumstances, DVT scanning should be done. Though DVT scanning is very important part of spinal cord injured patients, but there are no clear-cut guidelines or protocols which suggest when DVT scanning should be done or how frequently you should do it. But one should always keep in mind, to prevent the DVT thromboprophylaxis, it is recommended to start the low molecular weight heparin within 72 hours of injury. And if your patient has undergone surgery, so once you are sure that hemostasis is adequate and there is no hematoma post-operative, then you can start with the DVT prophylaxis with low molecular weight heparins. Otherwise, the mechanical thromboprophylaxis is recommended, and combination of the two is also recommended. Now, the thing is, these patients are going to be bedridden for a long time. So how long we should give the thromboprophylaxis? It's generally said that up to 3 months thromboprophylaxis should be done. But by rule of thumb, like, it's difficult to monitor the patients, and it is many of the places people say that till the muscle power is more than 3/5 or patient is at least able to move the limbs, the DVT prophylaxis should continue. In our center, after discharge, many of the patients are put on warfarin, oral anticoagulation for long periods of time, and especially at least for 3 months interval post discharge they should be given. So
Dr. Mitra,
yes.
Okay. As you have covered, I think, almost all the systems, and it gives us a deep insight how serious and grievous a cervical spine injury can. So it affects the cardiovascular system, the respiratory system, the gastrointestinal system, the urological system, the hematopoietic system. It affects the immune status. It affects the chances of getting infection. So one question I would like to ask you or get an opinion about from you is how often we get the condition called autonomic dysreflexia in patients with cervical spine injuries.
So autonomic dysreflexia is a pretty common condition which can be reported in up to 60% of the patients, which is because of the stimulation or the characteristically of painful stimuli, which can be bladder distension, it can be pressure sore, or it can be some pelvic manipulation or instrumentation, which leads to intense sympathetic surge at the level of the injury, and a reflex vasodilatation because of predominant parasympathetic tone above the level of injury, presenting as nasal congestion, vasodilatation, sweating, or headaches. And it is common. We see the patients, especially when and it is more common as the time after the injury increases. So this is a common condition which has to be dealt with.
Yes, so autonomic dysreflexia is an important condition which we should keep in mind while handling these patients, right?
Right, sir.
So now I would like to move on to Dr. Ranadhir, that with so much of systemic implications in patients with cervical spine injury, so how do you plan to go about the anesthetic management with particular focus on the airway, the various devices, maintaining these, trying to maintain the spine stability as much as possible, and the other implications like cardiovascular and respiratory system? Dr. Mitra.
Good evening, everybody, and thank you, sir, and thank you, RSACP, for the that we use. I think the most important thing to factor in while you are thinking of a device is whether the spine is stable or not, and secondly, the level of injury. Am I audible? Hello? Hello?
Yeah, your voice can be a little bit more clearer.
No, it's cracking.
Is it audible now?
Yes, yeah, it's fine.
Audible, sir. Please go ahead, sir.
Okay. Now is it clear? Is it clear now?
Yes, it's clear.
Yeah.
Randeep, speak. I think he got disconnected.
Dr. Randeer, you are muted. Randeer, you are muted.
I think move on with the next question.
Dr. Randeer, you are muted.
I think there is some.
Now it is audible, right?
Yes, sir.
Yes, audible. You are audible. Please
move on
carry
to
on.
next panelist.
Okay, actually, when we are talking of securing airway in a traumatic cervical spine, only two things has to be remembered. One is what is the level of injury, and second is how stable is the spine. So when you're talking of stability of spine, either you can you can take a shortcut and ask the neurosurgeon whether it is stable spine or not, or you can do a quick radiological review of a lateral X-ray, and if you see a translational injury where the vertebra above moves more than 20% of the distance, then you can say it is an unstable spine. Along with if there is a disruption of the articular joint or the discoligamentous complex, posterior and anterior elements, then you can think it is an unstable spine. The other thing is to the level of injury. If it is a higher level, above C3 and above, then you are more likely to use fiber optic intubation. If it is a lower level below C3, C4, C5, then you can think of video laryngoscopy with a bougie. Below C5, you can also use a direct laryngoscopy. And these are the two ways in which you decide what to use. And when you decide on a particular device, it all depends on your own expertise. At the end of the day, it is a airway. Airway takes precedence over airway takes precedence over the methodology of securing it. That is, if you are very comfortable with direct laryngoscopy and you are failing to secure it in any other way, then you can go ahead with the direct laryngoscopy. But the best option, the gold standard, would be a fiber optic intubation. And for fiber optic, generally what I practice is generally I only do, because this high cervical injury, they don't have a good cuff, and they can they don't have a good cuff, and they can easily tolerate the tube once it is in place. So I just give a transtracheal infiltration, and then I go with a spray as you go technique for avid fiber optic. In the background, a low dose either fentanyl or a dexmed, very low dose, and the like of 0.3 mics per kg per hour in dexmed and 0.5 microgram per kg per hour in fentanyl. Low dose may be run. And for video laryngoscopy, if you are doing video laryngoscopy day in day out, then that's a very good method. And I think a lot of people or the world is moving more towards accepting video laryngoscopy as a method of choice for intubating traumatic cervical spine. And these are the things. And for agents, if you consider what kind of anesthesia agents that you should use while securing airway, then if the patient is hemodynamically stable, there is no element of instability, then you can go for normally you can induce with propofol or thiopenton and give relaxant in form of scoline or ocuronium to secure faster airway if you are using GA for video laryngoscopy or for direct laryngoscopy. And if the patient is unstable or borderline stable, borderline instability is there, suppose a systolic blood pressure between 90 to 100, and there is an associated polytrauma cases where there is a blood loss is there, then you can go for a ketamine or a ketamine with propofol. These are the things that you can use. And rapid sequence intubation, when you are using in an emergent case, then obviously you can go for an RSI. But then again, we should remember that RSI, there is a chance that it might distort the airway. So airway, at the end of the day, it is the airway which takes precedence. So you might do away with an RSI and go for a quick intubation.
Yeah, thank you, Ranadhir, for putting the thing very straightforward. That first airway is the most important thing, and you should practice that technique in which you are facile. So stick to what you know. In this connection, I would just like to take your opinion about this technique called manual inline stabilization, which is considered as a point of care. Should we practice it, or does it make our attempt to intubate a patient with cervical spine more difficult? Does it cause more harm than good? What is the current status?
See, in manual inline stabilization, previously, even currently, a lot of centers still use manual inline stabilization when they are planning to go ahead for securing airway if you are using direct laryngoscopy or video laryngoscopy. So in those cases, they use manual inline stabilization. There are studies which have compared the degree of synofluoroscopic assessment of degree of cervical motion when you are using manual inline stabilization, going ahead with intubation, and without manual inline stabilization. Now there is definitely a decrease in spine motion, but that depends on how effectively you are applying manual inline stabilization. There are two ways in applying manual inline stabilization. One is operator at head, another is operator at front. The front will be facing the facing the patient, and he will be cradling the mastered process while supporting the occiput. If the operator is and if the person who is giving the mills, if he's in the head of the patient, then he has to cradle the occiput while giving traction on the mustard. And the only fundamental thing is when you are giving mills, the forces that the person who is applying mills, the forces he is applying should be just opposite to the force of the person who is intubating. Suppose the person who is intubating is going for an extension, then the person who is giving mills should try for a flexion, so that the head and the spine should remain in a neutral position. So yes, mills do help. There are studies to show that mills do help in reducing spinal motion. But yes, those are more useful when you're using direct laryngoscopy or video laryngoscopy. Then that adds on to reducing spinal motion. That is the take now.
I'd also like to invite a comment on the extubation of these patients. Whom do you extubate? Whom do you would like to go ahead with? Long intubation.
Yeah, generally there are a few ways in which you decide whether you should extubate the patient. See, there are two things: whether if the patient is operated and post-operative, just after the operation is over, you are thinking of on-table extubation, whether you should extubate that patient or not. And another reason, when the patient is already in ICU with a tube in place, and then you are thinking of extubation. There are two different scenarios. If the patient is been operated on and just right after the operation you are thinking of extubating the patient, then the two things has to be seen. One, whether the power of the preoperative phase has remained same or not. If the power has deteriorated after the operation, then there is no point in extubating, because then you are looking at a cord edema. And the second thing is how high is the lesion at the time of operation. If any lesion above C5, I think the best course of action would be to wait and not to extubate. This is my take. And if the patient is in ICU and after a prolonged stay in ICU and you have done whatnot, and then you are thinking of extubating the patient, then three things has to be seen. One, what is the amount of sputum production and how is handling the sputum? That is one. Second is vital capacity. This is one is what we call as a card formula, where we look at the forced vital capacity. Then we look at the sputum production, the amount of sputum, or that is how frequently we are doing suctioning. If it is more than 2 suctioning in an hour, then it is a high volume production of the sputum, which the patient cannot manage if you are extubating the patient. And the third thing is the PA2 by FI2 ratio. If the PA2 by FI2 ratio is less than 200 or less than 180, then I think you would be very careful while extubating the patient, because the patient is already having atelectasis and maybe pneumonia or something which you have undiagnosed, which is undiagnosed. So first of all, you should correct those factors. Improve the atelectasis, then correct the pneumonia, and then go for an extubation. So volume of sputum or the frequency of requiring suctioning, forced vital capacity, and third is the PA2 FI2 ratio. This will help you in determining whom to extubate.
And the last question from to you is: does steroids have any role? Your take on that, because still we are being forced to give a lot of methylprednisolone, quote unquote solumetrol, day in and day out in the operation.
I think that's a very gray area. What you're talking about, the NACIS trials are very clear that there is not much of a role. But the thing is, if you have a young patient arriving less than 8 hours of injury, then yes, you can go for a bolus and an infusion for at least 24 hours. You can give methylprednisolone. If it is a young patient, presenting within less than 8 hours of injury, then there is some subset analysis on NACIS trials do show an advantage, and even neurosurgeons follow it. And if it is beyond 8 hours, I don't think, other than creating some kind of severe acidity and gastritis and hole, I don't think there is much of a role beyond 8 hours. Yes.
Yeah, very true. So after the anesthetic management, the airway management, now we move on to our third panelist, Dr. Prakhar. So I would ask Dr. Prakhar to throw some light on the pain management, the prognostication in this patient, and of course the palliative or supportive care which these patients require very often. Dr. Prakhar.
Yeah, thank you, Dr. Indranil, and good evening, everyone. So queries regarding the outcome of after spinal cord injury is very frequently faced by us in the ICU discharge also, and are very difficult to answer. The most important determinant of prognosis in these patients is the extent of initial injury. Dr. Bindra has already talked about the ASIA scale, the American Spine Injury Sufficiency Scale.
Dr. Prakhar, your voice is getting cracked. Audio.
One second.
Audio and video.
Okay now?
Video both. Yes.
So your audio is cracking actually.
Prakhar, put on your video.
Yes, now we can see you. Now we can see you, Dr. Ganesh. Yes.
Yes, ma'am. So the most important determinant in this
Your voice is
Your
cracking,
audio
Dr.
is
Prakhar.
cracking. Your audio is cracking, sir.
Hello.
No.
Prakhar, sound नहीं आ रहा है, crack हो रहा है.
Yeah. Let me change my.
Ganesh, remove your earphones and use the computer audio.
Dr. Indranil, I think in the meantime we can
take
get the discussion on with the Dr. Shishbindra and Dr. Ranadhir Mitra, please. Or if there is any question, I mean, we can take up it now.
There is one question in the chat box which has already been answered by Dr. Mitra. Yes.
That is regarding steroid.
Yeah, regarding the use of
That's already
steroid.
been discussed.
In our institute, we are not very commonly going with steroids, even within 8 hours injury, where we very commonly use this intraoperatively when we are expecting some injury or some nerve tract injury or spinal cord injury or acute damage to the cord. Generally, we don't go for high dose steroids in our setup. Not even in young patients, or it's very less commonly practiced at the institute.
So in which cases you use the steroids, ma'am? In which cases you use?
The indications remain the same, that if very young patient is there with lots of cord edema and within 8 hours of injury somebody is coming, so their surgeon may choose to start steroid. Generally we do not give for the injury, traumatic spinal cord injuries. We go for during intraoperative period when we are expecting like some cord manipulation or some nerve injury. So they are the cases wherein more commonly we are using.
Ma'am, I want to come in.
Yes, sir, please.
Yes, actually, if you look at the reason why you use steroids is because of the glucocorticoid activity. Now, if you compare dexamethasone with methylprednisolone, the glucocorticoid activity is much higher in dexamethasone than methylprednisolone. Now, I want to know if any panelist or anybody out here can tell me, because I have this doubt, why you have chosen methylprednisolone for the trials when you have dexamethasone. Can anybody tell me? Because I didn't find anything in the literature also why you have chosen methylprednisolone over dexamethasone. Well, the glucocorticoid activity of dexamethasone is quite high. So why you have chosen that? And secondly, how did you assess the outcome in the NASIS trials regarding when you used methylprednisolone? Those are very incomplete trials where the outcome has not been analyzed properly. So I think still we are dealing with neurosurgeons' wish and fancies, that he decides that where you should give methylprednisolone and where you should not give, because nobody actually because there is
generally a neurosurgeon's prerogative only. But the thing is, like when the ball is in your court, you have to hit it. You can't just say that I don't know. So you have to have your own criteria, probably when to give, when not to give, wherever, and it is surely dependent upon whether we want to give or not, because there are no clear-cut guidelines for this.
Risk of infection is very high if you're giving
Maybe Ankur wants to answer it. Ankur, you can take that.
Ma'am, it's just that we are following the guidelines, the 2013 guidelines on the acute traumatic spinal cord injury. There is a class 1 contraindication to the use of steroids in traumatic spinal cord injury, as well as in traumatic brain injury 2016 guidelines. There is a class 1 contraindication to the use of steroids in TBIs. And that is what I've done in my hospital. I've attached the posters in EDs, do not use steroids in traumatic brain injuries and traumatic spinal cord injuries.
That's true. But like in patients with the brain injury with a nerve entrapment, like optic nerve entrapment, maybe a bowl of steroid helps. So surely it's not a good indication to use steroids in traumatic brain and spinal cord injuries. But yes, wherein there is an outright thing which is edema or compression, which can where steroids can help. Maybe they are an option in very, very few cases, but surely there is no evidence, and there are no RCTs also.
Yeah.
So if we have
and regarding the
old, then we don't have even, we are still not answering that questions. We are not giving in one group, and we are not randomizing patients to receive. So as old the evidence, same is old is the practice. So it is difficult in some situations. That is why in such gray areas it becomes a, it depends upon surgeon's prerogative or your own prerogative.
I think we'll have a next date for this debate when we meet at the AIMS.
I think Dr. Prakhar
is back. Prakhar, please continue.
Dr. Prakhar.
Yeah. So can you hear me now?
Yes, you're audible, sir. Please go ahead, sir.
Audible.
Okay. Yeah. Okay. So I was talking about the prognosis of these patients after spinal cord injury, and the most important determinant is the ASIA scale done at 72 hours after injury. Dr. Bindra has already talked about the ASIA scale that creates the spinal cord injury into complete and incomplete spinal cord injury. And generally, those patients who are having incomplete spinal cord injury do better than the complete ones. Another scale which is commonly used is the spinal cord independence monitoring scale, or the SCIM scale, the third version of which is currently being used. This scale is used during the neuro rehab stage to predict the outcome. So basically, we use the ASIA scale and the SCIM scale to get the final outcome of these patients. Now, the patient parties and the caregiver generally ask when will they be able to move their hand, will they be able to walk, etc. So there are different predicting models for assessing these things. As for example, it has been found out that most of the patients, even those with complete spinal cord injury, are able to get some amount of hand movement back after 3 to 6 months, especially if the level of injury is below C4 level. However, only 5% of those with complete spinal cord injury will be able to walk during their lifetime. And as for the bowel and bladder involvement, most of these patients are going to have some amount of bowel and bladder dysfunction during their lifetime, and this has to be addressed during the neuro rehab phases. In addition, the age has a very important prognosticating factor, and higher age has been found to be poorer outcome in these patients. Another thing is the treatment in the first 48 to 72 hours of the patient. The initial management, if done good, leads to better outcome for the patient by preventing the secondary injuries. And in addition, MRI by itself is a poor prognosis of indicator of prognosis for this patient. So basically, to summarize it up, you do an ASIA scoring at 72 hours, and to see the scale. If the ASIA scale is higher, C, D, or E, then you get a better outcome. And the ASIA scale is in lower, complete A or B, the outcome is poorer. But most of these patients will be able to get some amount of hand movement back.
Okay, so we have a fair idea about how to prognosticate. Now, throw some light on the pain management, chronic pain management, and the palliative care of these patients, home care, palliative care.
Yeah, the chronic pain in these patients is difficult to manage, and it's very unfortunate because they are not having sensation, but they are having pain. Some studies have found out that the pain incidence can be as high as 40 to 80%. And 30% of these patients can be having very severe pain after injury. And pain by itself is a predictor of the satisfaction of life after survival in cervical cord injury. In one study, they even found out that the patients were grading pain relief as higher than hand movement or leg movement. So it's very important to control the pain for after spinal cord injury. The pain pathophysiology is because of the neuroremodulation. The pain can be above the level, at the level, or below the level pain. And categorizing them according to this formula leads to better management of the pain. So above the level pain can be nociceptive from the musculoskeletal system, etc. At the level pain is the level pain at the level of injury, and 3 dermatrons below that, and can be radiculopathic pain. And below the level pain is generally neuropathic pain. These patients have low GABA and low norepinephrine receptors in the spinal cord and high glutamate receptors. To manage this pain, there can be pharmacological and non-pharmacological methods. Non-pharmacological methods include methods like TENS or exercise or biofeedback. And pharmacological methods commonly used are, we use anticonvulsants like pregabalin or gabapentin, and antidepressants like amitriptyline, duloxetine, nortriptyline. In addition, we use analgesics like paracetamol and opioids and their attendant risks. Botulinum toxin injection is coming up for pain management in these patients, but ultimate pain outcome, especially in those in severe cases, can remain poor. And it's very unfortunate that some of these patients can have the pain starting after 6 to 1 year after the injury and can persist for a very long time also. As for the palliative care and the rehab for these patients, it's very important that we first address, sit with the patient and their caregivers, because a lot of these patients, they have very high depression. And one of the leading causes of death after survival from cervical cord injury is suicides. So we sit with the patients and their caregivers. We assess their injury through the SCIM score, and then we make a SMART goal, that is specific, measurable, attainable, reliable, and time-dependent patients. And with these SMART goals, we go for the functional recovery. Most of the functional recovery occurs during the first 3 to 6 months of these patients, but sometimes the recovery can be prolonged for 1.5 years. After 1.5 years to 2 years, recovery is very slow. So in addition to the functional recovery, we have to take care of the complications of spinal cord injury. Dr. Bindra has already enumerated all of these. Most important is the bowel and the bladder involvement. So bowel treatment includes training the patient with good bowel habits, maintaining a bowel diary, maintaining a bowel time, food, adequate fluid intake. Bowel bladder treatment is with pharmacological and non-pharmacological methods, because most of these patients will be having a neurogenic bladder, and some pharmacological methods are used to treat the neurogenic matter. In addition, in cervical cord injury patients, most of them will require long-term catheters and CIC, and may have UTIs and urinary stones, as already been told. Other techniques for bladder management is the Valsalva and the crate maneuvers, in which the patient can use these maneuvers to empty their bladder themselves. Other important thing is to prevent the pressure source of the and the food habit of the patient. To maintain the GI, the bone density, good exercise, maintain a daily routine for this patient, and ultimately lead to a better outcome for this patient. But after acute spinal cord injury, especially if the injury is in higher level, as we know, most of these patients are not going to survive the first 7 days, and almost 60% of the patients, they die during the first week. They have frequent hospital visits during the first year, and the major cause of death in these patients is infection, as told before.
Yeah. So I think, Dr. Prakhar, you have covered all aspects of pain, prognostication, and the holistic and palliative care of these patients. And all the, over a short, brief period of time, all of you have highlighted the important areas which the cervical spine injury affects. All the systems are affected: airway, respiration, circulation, musculoskeletal, gastrointestinal, urological, the immune status. Anesthetizing these patients can be very challenging, very tricky. Intensive care management of these patients are quite, they drain out your efforts completely. And last but not the least, the pain management, the prognostication, and the palliative or holistic care of these patients. It implies that still a lot needs to be done. A lot of trials, research needs to be done, both from the anesthesia intensive care side and from the surgical side, so that in the coming years, we can give a much better outcome to these people who are unfortunate to have a cervical spine injury. So with this note, I thank all our panelists for giving your valuable time to discuss such a pertinent topic. And I thank the organizers of RSACP West Bengal branch for having us today for this important discussion. Thank you.
Thank you, Dr. Indranil, and thank you, Dr. Ashish, Dr. Prakhar, and Dr. Ranadhir Mitra for being with us, and thank you for taking us through a very captivating and informative session. I would request Dr. Sarbari Madam to now give her inputs and close the session and give a vote of thanks prior to the end of the webinar. Thank you. Dr. Sarbari Madam, please.
Okay, thank you, Dr. Kasturi, for conducting this scientific session seamlessly. Though we have some problems like technical problems and network problem, which happens regularly almost. But we didn't hear anything from Dr. Tejkol sir today. I'd like to request sir to say just few words for us.
Thank you very much, Dr. Sarbari. You have done a great job. Thanks, RSACP West Bengal chapter. Thanks all the speakers, the chairpersons. All the 3 sessions have been excellent, very informative, and everyone remained glued to the speakers, what they were speaking. The discussion was of a very high order. I must thank, in addition to the organizers, Dr. Vishal, Dr. Indrani, because everything happens under their guidance and under their patronage. Thank you all. Thank you very much for making the session very, very lively. God bless you. Long live. Thank you. Thank you.
Thank you, sir. Thank you for your blessings, as it is always with us. Your blessing is very important for us. So I take this opportunity to thank all the speakers and chairpersons for enriching this program with their knowledge and experience and giving their valuable time. Extend my heartfelt gratitude to Dr. Indrani Hemant Kumar Madam, President of the Society, Dr. Tejkol sir, our patron, Dr. Naveen Malhotra sir, our President-elect of RSACP, and Dr. Vishal Singla, the Honorary Secretary of the Society, and all the GC members of RSACP for participating and encouraging us to achieve the endeavor. It is my pleasure to thank the dignitaries, including postgraduate students who were present here, for participating on this beautiful evening. Thank you very much. I'm taking the permission of the society. Shall I close the session, sir? Singla, sir, please.
And Dr. Indrani, ma'am, please.
It was such an excellent, enriching session. Dr. Goswami, it was all praise and no brickbats. It was fantastic. And the panel discussion was complete. And, it was a pleasant surprise to see Ganesh Prakhar, who's one of my students. So nice to see him. I didn't even know that he was in Kolkata.
Thank you, ma'am. Don't have to see you all so much.
Really nice to see. Yeah, and fantastic discussion, and really enjoyed the entire session, and having Paul sir attending from the beginning to the end. I mean, really grateful to you, sir. It was fantastic session, and I thoroughly enjoyed the whole thing. Thank you so much, Sharbari. It was really enriching.
Thank you. Thank you, madam. Thank you, sir. Thank you, Dr. Vishal.
Thank you very much, madam, and long live RSACP.
Long live RSACP.
Next webinar. Thank you.
Thank you, ma'am.